I was tasked with presenting on anomalies in the late first trimester. And I was thinking about how to give this talk, and I think because it's an interactive course, I'm going to do 4 cases and just get opinions from the audience, just like Dr. Canavan did, through each image I present as to what you think is going on. And I wanted it to sort of be practical for real-life practice and not necessarily focusing on detailed anatomy ultrasounds in the first trimester, but if you're in a community doc and you get an image on a nuchal that you're sort of concerned about, how would you then make next decisions? And so that's how it's going to sort of progress, though they are all cases that were done at McGee. I have no disclosures. And so as far as learning objectives, identifying abnormal anatomical findings in the first trimester with non-anatomical ultrasound indications, understanding the utility of directed transvaginal ultrasound in this context, determining the role of genetic screening, counseling, and management, developing reasonable ultrasound follow-up plans, including reevaluation of anomalies, and acknowledging limitations and uncertainty of first trimester ultrasound. So for a number of these cases, I'm hoping to show you how things evolve, sometimes unexpectedly. So this is an outline that is sort of how I tend to think about abnormal first trimester anatomical findings. I think there are some that are clear and severe anomalies, your acranias and similar types of findings where there's more appropriate for directive counseling, obviously in consideration of patient values. Then there are things that are likely anomalies, but where you might need to acknowledge some degree of uncertainty and consider follow-up ultrasound before committing to any permanent decisions. And then subtle findings that may or may not indicate anomaly, the classic one being sort of physiologic gut herniation versus abdominal wall defect. And in these cases, obviously, permanent decisions should not be encouraged without further information. So case number 1, patient AZ, presented at 12 weeks, 0 days gestation for nuchal translucency. This is the baby picture that the sonographer took to provide her. I'm going to move this way. So I hear uh-oh from the crowd. What are people seeing that making them think uh-oh? I'm having trouble hearing, but yeah, so a head. I see people pointing at their head. Yeah, so when I saw this case, was immediately struck by the calvarium anteriorly appearing basically to bulge out more than one would anticipate. This is the actual nuchal translucency image that we obtained, and it's, again, transabdominal, so not ideal, but you can still see that it's bulging anteriorly. Nuchal looks okay. I mean, it's not the best, but, it's not thickened. So then we went to transvaginal imaging. Anything anybody's seeing in this image that is different yet? I'm going to show some other views, but still I imagine the similar concern. So this is an axial view. What are people thinking based on this view? Sorry? So there's midline falx, okay, but the choroid, what's going on with the choroid? Posteriorly displaced, right? And classically, what does that finding suggest? Sorry? Yeah, obstruction of some sort. So I'll show you a couple other images. So again, posteriorly displaced choroid, midline falx is visualized. So at the time, we suspected evolving fetal hydrocephalus. I'm going to take this case forward. She had a genetics consultation. There was a family history of hydrocephalus and intellectual disability that was elicited. She elected cell-free fetal DNA testing, low probability of trisomy 21, 18, and 13, and had a suspected male fetus. Is there any other genetic testing somebody might do? In this case, male fetus. Yeah, there was nothing else that was sort of immediately popping out. I'm sorry? Normal, yeah, well, normal at the time, yeah. So we couldn't find any other anomalies. So I should have probably provided some additional images, but I'm just showing the images of the things that I thought were interesting in the cases, so I apologize about that in advance. But yeah, there was nothing else that was concerning on those initial images. So yeah, so we sent L1 CAM testing as a screen for X-linked hydrocephalus. It ended up returning negative. So about 30% of X-linked hydrocephalus is due to a mutation in this gene. So I brought her back at 16 weeks and 0 days for follow-up. And now what do you think about the ventricles? It doesn't look as prominent as we sort of expected it might. Then there is also this image. What do you guys think about that? She's only 16 weeks, exactly. So there was a concern brought up for possible inferior Vermean hypoplasia, but again, if you look at this image, you can see that it's certainly not a dandy walker, and the fact that she was 16 weeks was thought to be a reason to not be too concerned about this immediately. But the other thing that's noted, and I don't have too many images of it, but we never saw cavum septum pellucidum at this point. And we did transvaginal imaging again. So here's another image. Again, you can see the midline folks. Everything looks even bilaterally. So the impression at this point was, and this is actually impressions lifted from the reports, cannot exclude inferior Vermean hypoplasia. I guess the sonologist thought there could be a banana sign based on this, but that ended up being not true. Cavum septum pellucidum was not visualized, and there were prominent anterior horns of the lateral ventricles. Okay, so now she comes back for an anatomical survey. Ventricle measures normally. What? Yeah, so colpocephaly, right? So there's a teardrop shape to the lateral ventricle. See, it narrows anteriorly, and so there was that concern. And again, the cavum septum pellucidum was also not visualized. This is anteriorly, can't really see anything. The cerebellum looked normal. And there was an attempt at transvaginal ultrasound to see a midline sagittal view to visualize the corpus callosum. Unfortunately, this isn't a perfect midline view. We couldn't get a great view, but no pericallosal artery was able to be visualized on this ultrasound. So the impression was probable absent cavum septum pellucidum and possible agenesis of the corpus callosum. So what would you guys do next in this circumstance? A lot of places would do an MRI. At McGee, we don't end up doing MRIs. Because they couldn't get a perfect view. I think that was still considered the most likely diagnosis, but because we couldn't get a great midline sagittal view, it wasn't clear that the reason we weren't visualizing a pericallosal artery was positional versus that it wasn't there. But I think that was clearly the highest suspicion. Sure. Okay. That's fair. That's fair. That's fair. Why not? So she declined in amniocentesis. She declined invasive testing after the genetic. Mm-hmm. So invasive testing was recommended for her, but she declined it. So our practice in these cases is to recommend invasive testing first, and then only if they decline it, offer, and with acknowledging the limitation, cell-free fetal DNA. So I'm showing what happened in the case as opposed to what our sort of standard recommendation would have been. But I completely 100% agree with you that cell-free fetal DNA is not the appropriate genetic test in this context. Okay, so she came back at 31 weeks and 6 days, and I just wanted to show this as a sort of final imaging. So got coronal views on tomography, and on none of these images can you see a crossing corpus callosum. To remind people of normal examples of corpus callosum, coronally you should see this bridging band here. This arrow is showing the CSP, not the corpus callosum. And then obviously showing the pericallosal artery over a very nice hypoechoic corpus callosum sagittally. Those are not from this case. So, final impression, this is the final ultrasound that she had during her pregnancy, was probable agenesis of the corpus callosum. So the outcome of the case, so she had a spontaneous vaginal delivery at 41 weeks gestation. Postnatal MRI showed agenesis of the corpus callosum and interestingly showed Vermean hypoplasia. So although we sort of dismissed it after she returned from the 16-week scan, on the MRI postnatally, there was concern for that. The baby had a normal karyotype in microarray, and at 7 months old, evaluation showed abnormal EEG, cortical visual impairment, and developmental delay. And these are some images from the MRI just showing the lack of a corpus callosum in either of these views, and then showing the slight Vermean hypoplasia. Certainly not the prominent feature of this, but suggestive of a neuronal migration disorder. So case number 2. Again, 13 weeks and 3 days, patient comes presenting for nuchal translucency. And this is how you often will capture a number of these patients if you're not routinely doing first trimester anatomy ultrasounds. So I'm just showing as the image of the nuchal. Does anybody have any concerns yet, other than you're not getting the nuchal ideally? What? And I hear the face. So it'll become a little bit more obvious with subsequent images. So I'm going to show some sort of ugly abdominal images first before we go transvaginally. But what about this image? It's not a perfect axial view by any stretch of the imagination. But does anybody have any concerns that they can see on this image? Sorry? Orientation. So let me show you a clip, because it might make it a little bit clearer. So they're not two babies, I'll tell you that now. It's just one. But this is a large anterior defect, and I'll show a ventral wall defect. So I think this is the best image we got, suggesting that there might be partial ectopia cordis, though it's not blatant. So let me now show you some transvaginal images, because now we can see a little bit more clearly. I think this is a clip. No, that's just a still image. Well, what do you see in the still image? What is this structure? So this is the stomach, and it's not, you'll see in the clip inside the baby. I think I put the clips out of order, but, and then this is, I must have put images and then clips, so I apologize about that. So this is, what do you see in this image before we get to the clips? Yeah, so very abnormal curvature of the spine. So what are people thinking diagnostically before we get to the clips? Body wall, yeah. So let me show the clips. So you can see the large ventral wall defect, stomach is in it, liver. Don't see the heart as well in this clip, but, and then let me show. Other thing that goes along a little bit with limb body wall is you can have abnormal extremities, and you can see that what we thought was a club foot sort of pop in very briefly there. But obviously you see the kyphoscoliosis, it's very severe. At the end of this clip, you see what may be a short umbilical cord here. So it's not immediately opposed to the placenta in this case, but it still would be consistent with suspected limb body wall. That's the best image that we could get of the cord. So it looks like sort of a little short and irregular, but it's not immediately opposed to the placenta, which you might typically expect with a body stock anomaly. And then you can see that there's bowel here in the sac. So the other thing that was on our differential was an amniotic band or abdominoschisis. And so the impression was body stock anomaly versus amniotic band syndrome. The liver, stomach, and bowel were thought to be contained in the abdominal wall defect. There was possible partial ectopia cordis, kyphoscoliosis of the spine, possible club feet, and irregular cord insertion and amnion. This is not this baby. That was just an example. So she had a genetics consultation. At our hospital, often we have to go through the genetics division prior to sort of getting to fetal diagnosis. She elected no genetic testing, which I should have said with the prior one that she elected no invasive testing, and just repeat ultrasound. Follow-up at 14 weeks and 5 days showed a fetal demise. She had a dilation and evacuation after the fetal demise. There was a normal karyotype, which would be consistent with these diagnoses. These don't tend to be associated with aneuploidy. Now, I just wanted to show a retrospective look at the 7-week, 5-day scan. So she'd had a viability scan at 7 weeks, which was called viable fetus. But I think it's interesting looking in hindsight. You can kind of see what looks like possible ventral wall defect here. And actually, the embryos, possibly like an irregular curvature to the embryo. But this wasn't noted at the time, but I think when you look back, you can see some suggestion of it even then. I think it's interesting to see how early, with modern ultrasound machines, you really can start to see findings from anomalies. Obviously, this is a severe anomaly, but this is only a 7-week embryo. So case 3, again, a patient presenting for nuchal translucency at 11 weeks and 4 days. And this is, so what do you guys think about this? So cross-section of the abdomen. Stomach's there. Mm-hmm. Sorry? Worried about an abdominal wall defect? Does anybody think this could be physiologic gut herniation? Yeah, I mean, I think you have to keep that in the differential. She's 11 weeks and 4 days, so she's really at that tail end of when you would be expecting to see physiologic gut herniation. Really, by 12 weeks, that should be completely internal. But I think that just given the sort of shape of it, the prominence of it, and the sort of later end gestational age, there was some concern that this could in fact represent a pathologic defect. Here's another image of it. And I'm just trying to show a clip, but you can see as it like sort of blows past. It's pretty prominent in sort of its shape and appearance. So the impression was prominent fetal cord insertion cannot exclude abdominal wall defect. So we're apparently a hedging kind of place. But so I apologize about the non-committal diagnoses here. But right. No, I know. So we had her come back basically in a week to repeat the first trimester to assess the abdominal wall. And again, you see similar images. The color sort of showed the umbilical cord inserting anteriorly. And so this was thought to be an abdominal wall defect, suspected to be an omphalocele. So our general practice, if we diagnose something in the first trimester, is bring them back a little bit before the anatomy ultrasound to get more definitive images. In the case that patients would desire genetic testing or termination. I believe this patient did see genetics around this time, though I didn't put it in my slides, but she also declined testing. We don't have a lot of patients accepting invasive testing, and Pittsburgh, it's relatively rare to get that. So at 16 weeks, this is what it looked like. And I'm not going to like dwell on each of these images. I just want to show as it goes forward. But I think it's kind of interesting that you'll see as it progresses, the appearance of it looks a little bit less prominent. This is the cord here going into the defect here. It was read as probable omphalocele containing bowel and possible liver. There was thought to be a small portion of liver in it. Oh, right, she declined genetic testing, so sorry, it occurred after 16 weeks. And she came for anatomy ultrasound at 20 weeks. And here's what it looked like. So now it doesn't look nearly as prominent as it was before, but it's clearly there. Thought to be suspected omphalocele. I just want to show how it evolves over time. So this is 24 weeks. It starts to look a little bit less prominent and even isn't, that different in size than the coiling of the cord. But still thought to be suspected omphalocele. Then at 27 weeks, we had this image. This was thought to be the omphalocele. And then this was noted. What does anybody think this could be? Sorry? A varix. So it was read as an allantoic cyst, but possibly in addition to an omphalocele, which is sort of interesting. So we were becoming less confident in our diagnoses as we got advanced in gestational age. And then at 30 weeks, we again see the same thing where you see the sort of bowel-containing structure and then the cystic structure next to it. It was read as possible allantoic cyst versus vesico-allantoic cyst versus omphalocele. Now, interestingly, this patient did not get any other ultrasounds. She developed HELP syndrome and had a placental abruption, emergency cesarean delivery at 31 weeks gestation. A cord cyst was noted at C-section. postnatal ultrasound just showed a large umbilical cord stump with no herniating bowel. She had a normal microarray, and at 5 months old, just has a very small umbilical hernia that won't require surgical repair. So I just think that this is, again, one of those cases that shows that it's important to be careful in how you counsel patients early on, because findings can always evolve over the course of pregnancy. And sometimes they evolve in a more severe direction, but sometimes they actually become less prominent. And you wouldn't want somebody, to hear 30, 40% chance of aneuploidy and terminate without genetic testing or other follow-up. And then this is my last case. Now this patient came at 10 weeks and 2 days for a dating ultrasound. What is, anybody seen this image? Anybody see anything that's concerning to them? Right, so you see this very prominent area behind the fetal back, consistent with a cystic hygroma. This image, I'm trying to show it here. I don't know if it's showing up well on the screen, but you can see it here. Anything else that's concerning in this image to anybody? So yeah, does this look normal to people? Now, it's not an axial view, so it's hard to make too many interpretations about it. It's kind of an oblique view. Sorry? Now, so this was not, that finding in the brain was not commented on with this ultrasound, but it was read as a possible thickened nuchal translucency. I think we probably could have been more concrete about this one. And we recommended she come back in a week for an actual nuchal translucency assessment because she was prior to 11 weeks at that point. And this ended up being the actual nuchal measurement. So obviously substantially thickened at 6.8. And consistent with a cystic hygroma, and I'll show you some images of that. But then, of course, we paid a little bit more attention to the brain this time. And what do people think about this? Does anybody see? Well, what do you guys see? I don't want to just immediately give it away. One ventricle, right. So it's a monoventricle, which was the big concern. And of course, that's consistent with alobar holoprosencephaly. So we did transvaginal imaging, because this was our TA image. So transabdominally, so you see the evidence of the cystic hygroma going down to the abdomen, chest. And then this is the brain. Sorry? Yeah. So that was obviously the concern. And so this is just a clip going through. You can see the cystic hygroma the whole way, and then this big monoventricle, basically concerning for the holoprosencephaly. There's a final clip. And that's the monoventricle, and basically like a coronal scan. So the impression was cystic hygroma, skin edema, and suspected alobar holoprosencephaly. She had a genetics consultation. After counseling, she did elect termination and planned for karyotype and microarray on the products of conception. So she had a dilation and evacuation at 14 weeks gestation, and the karyotype on the pregnancy showed a ring chromosome 13. So if there's anybody in the crowd who doesn't know what a ring chromosome is, basically the distal ends of a chromosome are broken off, and the remaining ends attach and form a ring like this, and then you lose any of the genetic material that was on the distal ends that separated off. And so essentially in this case, she had functionally a partial monosomy 13 because she was missing the distal ends of that 13th chromosome. And we did a maternal karyotype, though it was not like, these are generally spontaneous, and maternal karyotype was normal, 46XX. So take-home points, I think limited first trimester anatomy is warranted. If you're doing a nuchal or you're doing something else, you're looking at the pregnancy. Even if you don't do first trimester anatomy scans at your institution, it's worth looking at some basic structures. When you have a concerning finding, please don't hesitate to do transvaginal imaging because you'll get much better images. And anomalous findings can evolve, so we have to always acknowledge some uncertainty when we're diagnosing things in the first trimester, which apparently we might be a little bit too proficient at. And then early counseling allows for optimal follow-up, genetic testing, follow-up ultrasound, and then decisions about pregnancy continuation. So I just want to thank Dr. Canavan, the AIUM, and my colleagues and my family. So, any questions?